Good morning, everyone. Today I am presenting the topic of hypothyroidism, its manifestations and management. In general, in healthy adults, the thyroid gland is approximately 4 to 4.8 into 1 to 1.8 into 0.8 to 1.6 centimeters without iodine deficiency, with a mean sonographic volume of 7 to 10 ml and weight of 10 to 20 grams. Thyroid volume is measured by the ultrasonography and it is slightly greater in men than women. It also increases with age and body weight, and it decreases with increasing iodine intake. This thyroid gland is one of the most vascular organ in the body, and its ultrasonographic measurements of the thyroid volume and even nodule size can differ markedly from size after devascularization and resection. How thyroid hormone is synthesized. Initially, the iodide is taken up by the sodium iodide importer in the thyroid follicular cell. From this from it is iodide is diffused into the apex of the thyroid follicular cells. Here it is transferred into the colloid via pendrin. After that, iodide is converted, inorganic iodide is converted to iodine by the thyroid peroxidase enzyme in this colloid, and it is inserted. This iodine is inserted into the tyrosine residues in the thyroglobulin, so that DIT or MIT is formed, which is diiodotyrosine and monoiodotyrosine, and it these two molecules diiodotyrosine combine to form T4, and one diiodotyrosine plus monoiodotyrosine combine to form T3. Then it is taken, this thyroglobulin, it is formed in the thyroglobulin. Then this thyroglobulin is taken back into the thyroid follicular cells by the endocytosis mechanism, and here it is the proteolysis is done by lysosome mechanism. Here proteolysis is done, and the T3 T4 is released into the bloodstream bag. And here there is also the mechanism of uh, then there is recycling of the iodine is done by deiodinization of DIT and MIT by iodotyrosine deiodinase, and T3 is also formed from monoiodinization of the T4 in the thyroid and in peripheral tissues. This is the this is how T3 and T4 is released into the bloodstream. Now, in this T4 is formed in T4 is formed majority in majority amounts. T4 is converted to T3 in the bloodstream. Uh, how thyroid hormones are regulated. Initially, hypothalamus releases thyrotropin releasing hormone to these TRH acts on the pituitary. From pituitary, pituitary TSH is released, thyroid stimulating hormone. TSH acts on the thyroid, and by this TSH, the thyroid releases T3 and T4. T3 and T4, then whenever it is increased, it by negative feedback mechanism, it inhibits the pituitary and hypothalamus, so that then TRH and TSH is decreased consequently. This is how negative feedback mechanism works. So when does thyroid doesn't work? When thyroid doesn't work, there will be hypothyroidism. Yeah, hypothyroidism. So patients of thyroid disorders present as hypothyroidism with goiter, without goiter, and hyperthyroidism with goiter, without goiter, also with euthyroid with goiter. So what are the causes of hypothyroidism? In hypothyroidism, you have with goiter and without goiter. With goiter, you have causes like Hashimoto thyroiditis, iodine deficiency goiter, drug-induced goiter like lithium, amiodarone, PAS, ethionamide, rifampicin. These all can induce goiter. Lithium is mostly used in psychiatry for bipolar disorders, so you have to take care of the side effects due to goitrogens and Riddle's thyroiditis. Without goiter, the causes are Hashimoto thyroid. Here also Hashimoto's thyroiditis, post-ablative radioactive iodine, and after thyroidectomy, congenital hypothyroidism, secondary hypothyroidism like Sheehan syndrome. These are the causes of hypothyroidism. So in hypothyroidism, iodine deficiency is the most common cause of hypothyroidism. In iodine sufficient areas, or Hashimoto's thyroiditis is the most common cause of hypothyroidism. So what are the common presentations? What are the symptoms of the hypothyroidism? There are dry and coarse skin in 76% of the majority of the people. You will see dry and coarse skin. Cold intolerance is seen in 64% people. Puffiness of the face is seen in 60%. Sweating, weight gain. These also comes under the majority. Paresthesia, constipation, aches and pains which are non-specific. These are the symptoms, and signs include absent ankle reflex, bradycardia, somnolence, diastolic hypertension, depression, anemia, menorrhagia, and infertility. These are the signs you see in hypothyroidism. Uncommon presentations that you see in hypothyroidism are hoarseness of voice, deafness, ascites, pericardial and pleural effusion, carpal tunnel syndrome, impotence, galacturia, amenorrhea, cardiac failure, and psychosis. These are the uncommon presentations. Psychosis you see in many of your cases. So in brain, you can see there is depression, decreased concentration, general lack of interest. In heart, you can see bradycardia, increased or decreased blood pressure. Majorly, you see increased diastolic blood pressure and decreased cardiac output. In kidneys, you see decreased function and fluid retention and edema. And liver, you can see increased LDL cholesterol, elevated triglycerides. And intestine, you see constipation and decreased GI activity. Reproductive system, you see decreased fertility, menstrual abnormalities, and may harm the development of infants. So Hashimoto's thyroiditis, which is in USA, above 50 years female will have 10% hypothyroid, and in 60 and above 60-year male will have 10% hypothyroid. And in India, prevalence rate of hypothyroid is quite high, but the data is not available. It is the commonest cause of hypothyroidism, Hashimoto's thyroiditis. Most of the patients will never develop goiter, and the symptoms you see are very gradual. So this is a difficult to diagnose case. So you can see painless goiter or no goiter. So what the investigations you see are TSH is decreased, TSH is increased, T3 and T4 are decreased, and you see TPO antibodies high in high titers. Almost in all the cases of hypothyroid, Hashimoto's thyroiditis, you see TPO antibodies, and the treatment is you give is lifelong thyroxine. What is viral thyroiditis? It is a painful the present common presentation you see is painful goiter, usually small, along with fever and sore throat. Initially you see hyperthyroidism due to inflammation of the thyroid gland. You see hyperthyroidism for 2 to 3 months, and then you can see hypothyroidism where the thyroid won't work for 2 to 6 months. Then you can see euthyroidism. In few patients, some of the patients will remain as hypothyroidism for lifelong. So the viral thyroiditis treatment could be aspirin or NSAIDs, and steroids should be given with 40 to 60 mg per day according to severity. And for hyperthyroidism, initial 2 to 3 months you see hyperthyroidism. For that you should give propranolol. This inhibits the conversion of T4 to T3. For hypothyroidism, you may require thyroxine for of dose 50 to 100 microgram, and euthyroid after 6 to 1 year of euthyroid, you can stop the drugs. Postpartum thyroiditis. It is a autoimmune painless inflammation of the thyroid gland that occurs within a year in 5% to 10% of all the pregnancies. So what is the mechanism in this? The presence of the residual fetal cells which are present after the delivery, they get attached to the maternal thyroid gland. These causes the inflammation. These induces the autoimmune reaction. So that autoimmune reaction after delivery, then the immunosuppression ends in the female. So the autoimmune reaction continues, and you can see autoimmune thyroiditis. In this postpartum thyroiditis also, you can see initially due to the inflammation, you see hypothyroidism for 2 to 3 months, and then hypothyroidism, same as viral thyroiditis, and euthyroidism. 25% of postpartum thyroiditis patients will develop hypothyroidism after 5 to 10 years of delivery. What are the atypical presentations of postpartum thyroiditis? Initially thyrotoxic phase followed by return to normal thyroid phase, or you can see hypothyroid phase alone. Initial test for the what diagnosis, how you can diagnose the thyroid. Initial test, you should always do TSH. If there is if there is deranged, then you should do the free T4 test. So if the TSH is in this hypothyroidism, you will see TSH is increased due to decreased thyroid hormones. You will see due to negative feedback mechanism, decreased thyroid hormones acts on the pituitary and hypothalamus, so that TSH is increased. So you can have the TSH raised in always in hypothyroid patients. And there is free T4 decreased, and total T4 is also decreased. T3 is a short half-life. You have T3 is a biologically active form, and it have a short half-life. And most of these from the thyroid gland, most of them the released hormone is T4. So you have to check for the T4 count. Initial free T4 is normal in the initial case. Due to compensation, T4 levels converts into T3. So you can see normal T3 levels in the initial phase of hypothyroidism. In the early hypothyroidism, majority will be normal. After that, you can see decreased T3 levels. So thyroid ultrasound, this is an unimportant test, and it is for nodules and all. You can do the thyroid ultrasound. Important tool in the follow-up of thyroid nodule if it is not to be operated. Thyroid scan. These test will show decreased uptake or increased uptake or normal uptake. You can for those who are having thyroid nodules, you can do this thyroid scan. So in the thyroid scan, if there is decreased uptake with goiter, then you will call it as a cold scan. So the causes could be thyroid carcinoma and thyroiditis. So for this, you should do FNAC, and after that you enact accordingly. If there is increased uptake with goiter, then it is called hot scan. It is seen in Graves' disease. If the thyroid scan is normal uptake with goiter, it is seen in adenoma, colloid goiter, and puberty goiter. For this also, you should do FNAC. So thyroid, common autoantibodies in thyroid, you can see TSH antibodies against the TSH receptor, and against thyroglobulin, and against thyroid peroxidase. Majority will be against the thyroid peroxidase. So what is the treatment of hypothyroidism? The dose of the levothyroxine, it depends on the severity degree of the hypothyroidism, general health condition of the patient, age of the patient. Usual replacement is 1.6 microgram per kg body weight. You should start with the low dose initially with the 25 micrograms. So if the dose is missed, if one dose is missed, then you should take 2 tablets on the next day. If 2 doses are missed, then you should take 3 tablets next day. If 3 doses are missed, then you should start with the regular dose again. When should you take the thyroid tablet? It should be taken on empty stomach, 30 minutes before the caloric meal in the morning. So in the follow-up case of hypothyroidism, you should ask the TSH levels to be measured, which is after 6 to 8. You should follow up with 6 to 8 weeks, and dosages should be adjusted accordingly. You should keep the target TSH to 1 to 2 microunit per liter. Once the TSH is stable, achieved, it should be estimated every year. So if the patient is on thyroxine, if the TSH is normal, what should be done? You should, if patient is, most of the patients are Hashimoto's thyroiditis, so they will require lifelong treatment. You should continue the thyroxine. You should not stop the drug. What are the interpretations? So if TSH is normal, if T3 and free T4 are normal, then it is euthyroid. Your thyroid levels are normal euthyroid. If TSH is high, and if there is a normal free T3 and normal free T4 or decreased, then you can say it is subclinical hypothyroidism. Yeah, or early hypothyroidism. You should not give any doses. If there is clinical symptoms, then you can start the dose. If there are no clinical symptoms, you can follow up the patient after 4 weeks, 4 to 6 weeks. If TSH is increased and if there is a free T4, T3 decreased, then it is called hypothyroidism. There you can start the dose. If TSH is low and if T3 T4 is high, it is called hyperthyroidism. If TSH is low, if free T3 and T4 also low, then you call it secondary hypothyroidism or Sheehan syndrome. It means it acts from the pituitary hypothalamus levels. So you can see all the TSH, decreased TSH, T3, T4. So what is Sheehan syndrome? If there is excessive blood loss during delivery, then the blood supply is decreased to the pituitary, so that TSH is decreased and T3 T4 also decreased. Uh, then you get hypothyroidism in that females. The other symptoms include no lactation, amenorrhea, weakness, if, weakness, lethargy, anemia, depigmentation of areola, shiny skin, loss of pubic and axillary hair, low BP. It means from the pituitary, all the hormones are decreased, so the manifestations are seen accordingly. So in this Sheehan syndrome, the treatment given to be hormone replacement therapy, including glucocorticoid, prednisone 5 plus 2.5 mg per day, and thyroxine should be given 75 to 150 microgram per day. If the lady wants periods, estrogen and progesterone preparations can also be given. Our goal is to maintain T4 level in upper half of the range. Here TSH cannot be used to monitor the therapy, because already it is from the above, it is the damage is happening, so TSH is not used for this monitoring. Hypothyroidism and pregnancy. During pregnancy, the thyroid requirement of thyroxine increases by 25 to 50 microgram per day during pregnancy. Even on mild thyroxine hormone deficiency, there are chances of low IQ and developmental delay of the child. So thyroid levels should be maintained properly. If in the normally thyroid hormone exists in two forms, which is in active free form and bound form, bound to thyroxine binding globulin. In pregnancy, there is increased estrogen, which causes increase in thyroxine binding globulin, and it also increases total T3 and T4 levels. However, free T4 and free T4 levels remains normal. So free T4 should be used in the treatment and follow up during pregnancy and not total T4. Hypothyroidism in elderly. In patients above 60 years, you should rule out the coronary artery disease, because if the coronary artery disease is suspected, you should start the thyroxine with a low dose, with initially 25 microgram or 12.5 microgram, and gradually increase the dose accordingly, because these thyroid hormones will precipitate the angina. So the dosage should be given accordingly, and initially cardiovascular diseases should be ruled out in elderly patients. What is myxedema coma? It is a prolonged form of the hypothyroidism. When there is precipitating factor, you see these symptoms. Precipitating factors include infection, trauma, stroke, cardiovascular hemorrhage, drug overdose, diuretics, and the signs and symptoms usually older. It is this myxedema coma is seen in the older patients. They present with mental confusion. You can see hypothermia, bradycardia, hyponatremia, hypoglycemia, hypercapnia, decreased WBC count, decreased hematocrit, and increased CPK level. And in ECG also you can see a low voltage ECG. So the treatment in myxedema coma is in patient comes with the altered sensorium and deranged all the altered sensorium bradycardia, then you should transfer the patient to ICU and IV levothyroxine should be given 500 microgram bolus followed by 50 to 100 microgram per day. This dose can also be given via oral route through NG tube. Then other things could be antibiotics, ventilation if required, hydrocortisone should be given, passive warming, uh, careful volume management should be done. As the T3 T4 to T3 conversation is impaired, leothyronine is recommended, but has these leothyronine has the potential to provoke the arrhythmias. What is myxedema madness? Uh, these when patient presents with the myxedema coma, you can see delirium with the auditory hallucinations, paranoid delusions. This takes the form of the psychotic depression or pure psychosis can be seen, and there are no cognitive impairment, and the treatment is thyroxine. Mainly the patient presents with altered sensorium and all the other symptoms can be seen. This is what myxedema madness is. What is sick euthyroid syndrome? In any acute or severe illness can cause, when you see the patient with any severe illness in ICU who are in ICU, you can see the abnormalities in TSH or T3, T4 levels. Uh, you, with underlying absence of the thyroid. There are no thyroid disease, but you can see abnormalities in the TSH and thyroid hormones. This is due to inflammation and which causes the release of interleukin 6. So most common pattern could be low T3 syndrome. You can see decrease in total and unbound T3 levels with normal T4 and TSH levels. There is in the T4 is not converted to T3, so you can see low T3 levels. Low T4 syndrome, very sick patients may exhibit this dramatic fall in total T3 and T4. The patient, those who have poor prognosis, can present with this. In acute liver disease, initially total T3, T4 levels increases due to thyroid binding globulin release. These levels become subnormal as the disease progresses. Renal disease is often accompanied by low T3 levels. In early stages of HIV, T3, T4 levels also rises. Then T3 falls with the progression to AIDS, but TSH remains normal. This sick euthyroid syndrome is supported by history of thyroid disease, absence of history of thyroid disease, previous thyroid function tests should be normal, and history of drugs that may affect thyroid hormones. So when you give drugs in patients, then you can see the abnormalities in the TSH and T4. Measurement of RT3 together with FT3, FT4 and TSH can confirm the diagnosis of sick euthyroid syndrome. Only resolution of the test with clinical recovery can establish this disorder. If patient comes out of the acute illness, then you can see the normal TSH and T3 levels. So in this patient, you can confirm the diagnosis of sick euthyroid. Thank you.